Welcome back to MLT 120. Today we're going to be doing the platelet lecture. We're going to be learning about the maturation sequence of platelets. We're also going to be talking about some disorders associated with platelets. If you'll look on this screen here, you'll see some examples of what the platelets look like, and we've already seen some examples of platelets under the microscope in lab. As far as the maturation for our platelets, the precursor for the platelets is the megakaryoblast, and that's found in the bone marrow. And platelets can mature in about 4 to 5 days. And the sequence of maturation is the megakaryoblast, then the megakaryocyte, and then finally the platelet. The platelets are cytoplasmic fragments of the megakaryoblast. They kind of break off, and we'll see what that looks like here in an image in a minute. But the normal size of our platelets is only about 2 to 4 microns in diameter, so they're pretty small. And they're anucleate, meaning they do not have a nucleus or without a nucleus. And they're slightly granular. And there can be about 2,000 to 4,000 platelets produced from one megakaryoblast. So just one blast, megakaryoblast, can produce lots and lots of platelets. Now let's look again at the flow chart for the maturation of our blood cells that we've been looking at all semester. Let's look up here at the top. We know that all of our cell lines start with the hematopoietic stem cell, and it has the potential to become any of our blood cells. But today we're going to focus on the megakaryocyte that ultimately leads to our platelets or our thrombocytes. And this is on the myeloid side. Remember, we split from the stem cell, we go to the myeloid side or the lymphoid side. Well, today we're focusing on the myeloid side that will give rise to the megakaryoblast and the megakaryocyte and then the platelet. Remember, we just said that the platelets are made up of cytoplasmic fragments. So these little projections that are coming off of the megakaryocyte, they kind of pinch off and form the fragment that ultimately becomes the platelet. So these little fragments that are being pinched off the cytoplasm become your platelets or your thrombocytes. So let's talk about the lifespan of the platelet. The lifespan is anywhere from 9 to 12 days usually, and 2/3 of the platelets are circulating around in your peripheral blood. The other 1/3 is sequestered or stored or hidden away in your spleen. And the turnover per day is about 35,000 platelets per day. So your platelets start out in your bone marrow, and then they circulate or they're stored or sequestered in the spleen, and then they get turned over or destroyed by the spleen or the liver. So what's your normal or average platelet count for a patient? The normal platelet count is 150,000 to 450,000 platelets per microliter. For normal platelet function, a person needs to have at least 100,000 platelets per microliter. And this means your platelet count, if it gets below 100,000, you will have bleeding tendencies. So you want at least 100,000 platelets. If you get or have a patient that gets below 10,000 platelets per microliter, it can result in spontaneous hemorrhaging. Hemorrhaging means it's the release of blood from a broken vessel that can be inside or outside of the body. Platelets must be adequate in both number and function for normal hemostasis. Hemostasis is stopping the flow of blood. Don't get hemostasis confused with homeostasis, because homeostasis is where you're dealing with the balances within the body, things like body temperature. Now let's just go over a list of terms you need to know that are associated with platelets and platelet function. Thrombosis is just meaning clot formation. Thrombocytopenia means a decrease in platelet count. This is our less than 100,000 platelets per microliter. Thrombocytosis is an increase in platelets. Hemostasis is a series of cellular and plasma-based mechanisms that seals and repairs blood vessels and maintains vascular integrity. And we mentioned it just a minute ago. Basically, it means the stop or the stop of the flow of blood. Thrombus is the clot that is still attached to the blood vessel wall. Embolus is a clot that is detached from the blood vessel wall and travels to organs such as the heart, brain, or the lung. And MPV is an acronym for mean platelet volume. This is the average size of our platelets. Remember, we can have giant platelets or we can have average size platelets within our samples. So you will sometimes see the MPV included in our CBC results. So let's talk about the platelet structure. We know it derives from the megakaryocyte, but let's go ahead and zone into some structures of the platelet itself. There's three main structural zones. The first is the peripheral outermost layer, and this is used for adhesion and aggregation. And it's also known as the glycocalyx, or the fuzzy outer coating of the platelet. Then there's the Sogel zone, which is the cytoskeleton, which is made up of the platelet's microtubules and microfilaments. And then there's the organelle zone, and this is the area inside that holds all the granules, things like the mitochondria and the dense tubular system. And you can see here on the image where we're going from our megakaryocyte, the outside edge of the cytoplasm is being pinched off to form the platelet, and then you get a zoomed in image of what all the organelles and things inside the platelet look like. Now let's talk about platelet function. Of course, platelets help maintain capillary integrity by stopping the flow of blood if there's any injury. But there's three main functions of the platelets. There's adhesion, aggregation, and secretion. So let's talk about each one of those. An adhesion is where platelets are able to adhere to the subendothelium of the vessels after there's some sort of injury. There's something called von Willebrand factor that acts as glue that allows platelets to be able to stick to the membranes or to adhere to that subendothelial lining to help begin the stop of the blood flow when there's an injury. Upon activation, platelets change shape from a disc to more of a sphere shape. During the aggregation step for platelet function, platelets start to stick together and they start stimulating agents or antagonists like collagen, ADP for energy, epinephrine, thromboxane A2, and serotonin. And during the secretion stage, granules release contents during adhesion and aggregation. And you can see the little chart down there at the bottom, or the images showing the different steps of platelet function. There's normal platelets that are flowing along in the blood, but when there's damage to the vessel wall, see, this is the vessel wall here, but in this case there's been some kind of damage to the endothelium, and so the platelets have been activated. So they've started to change shape, and they're going to start to stick to this endothelium or the lining to try to repair it. And those platelets are going to start piling up or sticking together to try to help repair that damaged vessel wall. Now we need to discuss some different platelet disorders. Platelet disorders are either characterized as either quantitative or qualitative. If they're quantitative, it means there's a decrease in the number of platelets. If it's qualitative, it means there's a problem with their ability to function. There's a problem with the platelet able to do their job. First, let's discuss the quantitative disorders, or the disorders that's dealing with decreased numbers of platelets. First up is our thrombocytopenia, which the definition is just low platelets, and we're talking about less than 100,000 platelets per microliter. You can see small vessel bleeding in our capillaries, and you can see three different possible categories of bleeding in the capillaries. You can see petechia, which is pinpoint bleeding, and the pinpoint bleeding causes about 1 millimeter dots of red spots on the skin. And you can see that here in this first image to the left hand side. And then there's purpura, which is bleeding in about 3 millimeter splotches. This is an example of purpura. And then there's ecchymosis, which is larger spots of bleeding, which can range from 1 centimeters to larger patches, or just overall what looks like bruising of the skin. And you can see an example right here in this last image on the right hand side of ecchymosis. So what are some primary causes for thrombocytopenia? Well, first is decreased platelet production. So you end up with not as many platelets as you need. Increased platelet destruction by the body, or abnormal platelet distribution, or they're sequestered in the wrong place in the body. So you, for thrombocytopenia, your normal platelet count is, remember, 150,000 to 450,000 per microliter, and thrombocytopenia would be much lower than that. That's less than 100,000. So deficient platelet production, it can be problems with decreased megakaryocytes, which can lead to decreased platelets in the bone marrow, or ineffective thrombopoiesis. And some examples of conditions that can lead to deficient platelet production is Fanconi's anemia, or aplastic anemia, or some of your leukemias, alcoholism. It can also be drug-induced. Also, some viruses can lead to decreased platelet production, and congenital disorders such as May-Hegland that we have studied when we're talking about our white blood cell diseases. So we have something in the body called thrombopoietin, or TPO. The liver produces TPO, or thrombopoietin, which stimulates the bone marrow to produce our platelets, or our platelet precursors. So they can produce platelets. Much like our kidneys produce our erythropoietin, or our EPO, to stimulate our blood to produce red blood cells, our liver does that and produces our TPO to tell our bone marrow to make platelets. So patients with liver disease often have low platelets because their liver is not producing TPO. There's a couple of reasons why the body usually has increased platelet destruction, and these are destruction due to immunologic responses and destruction due to either just mechanical damage within the body, or consumption, or sequestration within the body. These are the reasons that the body has increased platelet destruction usually. So there can be abnormal platelet distribution or dilution within the body. Normally the spleen sequesters about 1/3 of a person's platelets, and the rest of the platelets should be in the peripheral blood. If the spleen sequesters greater than the normal amount of platelets, you can see a low platelet count in the peripheral blood. And this will cause hypersplenism or splenomegaly, which is an enlarged spleen, and this is the cause of increased sequestration. And it can basically look like you have less platelets than you have. Now let's talk about thrombocytopenia due to increased dilution. This is when patients have massive bleeds and they receive transfusions. They can have decreased platelets due to just overall dilutions from those massive transfusions. Because the blood in the transfusions they get are mainly red cells. The platelets and the white blood cells have been removed. Often these patients have to get platelets along with the red blood cells when they receive many units, because their platelets in their body get diluted out because of the red cells they have received during the transfusion. Next is idiopathic thrombocytopenia purpura, or ITP. It can also be called immune thrombocytopenia purpura because it is a form of the immune response. There's two types. There's the acute ITP, which usually occurs in childhood, and then there's the chronic ITP, which usually occurs in adults. Let's first talk about the childhood ITP. It usually happens in young children, usually from early about 4 weeks, and it usually results from a virus or a vaccination. And again, it's acute. It usually lasts 1 to 3 weeks, sometimes can maybe last a few months, and usually causes bruising and petechia on the skin. Usually is self-limiting, which means the child can recover on their own. Adult ITP, again, is chronic. It usually happens more often in women in the ages between 20 and 50. Occasionally, it will show up after a viral illness or an exposure to a certain drug. You can see bruising and petechia on the skin. Adult, again, because it's chronic, it usually does not get better on its own or spontaneously get better on its own. You usually have to get some kind of treatment for adult ITP. Next is TTP, or thrombotic cytopenia purpura, also called microangiopathic thrombocytopenia. It's rare. It's often fatal. About half of these patients usually have some type of history of a virus before they are diagnosed with TTP. It's usually acute with severe thrombocytopenia, and the platelet count is usually less than 30,000. And there's several other symptoms and lab findings that are associated with TTP that are listed here that you can read through on your own. The last disorder we're going to talk about in the quantitative category is thrombocytosis. It's an increase in platelets. The platelet count is usually greater than 450,000 platelets per microliter. And this is usually from a secondary response to inflammation, and it causes a reactive thrombocytosis. Thrombocytosis can also be caused by a myeloproliferative condition such as polycythemia vera, or PV, or chronic myelocytic leukemia, or CML. If you look over in the image on the far right-hand side of the screen, you'll see what you would see under the microscope. You have all your red cells, you have an example of a white cell, and you see an increased number of platelets. There's lots and lots of platelets on this field of view in the image shown. So now let's talk about or cover quantitative disorders dealing with platelets. This is when your platelets do not function properly. The first disorder in this category is the Menard-Sawyer syndrome. This is an inherited autosomal recessive bleeding disorder. The deficiency is of the platelets GP1B95 complex. This is a glycoprotein platelet receptor, okay, which is involved in the von Willebrand factor dependent on contact adhesion. Remember, part of the platelet function is adhesion, being able to stick together. Often with these patients, you see giant platelets in a blood smear. Usually with this syndrome, the platelet aggregation with restocetin is abnormal, and restocetin is an assay that measures platelet aggregation with the help of von Willebrand factor. If you look over here on the far right hand side of your screen, and it shows you the inheritance of this syndrome, both parents have to be carriers of the gene for the disease in order for a child to have a chance to be affected by Bernard-Soulier disease. So your platelets have different receptors stuck on the surface of the platelet. So this is your platelet, and these are possible different receptors that are stuck, or to illustrate different receptors that can be stuck to the surface of your platelet. For Bernard-Soulier syndrome, it is the GP1B95 receptor that it is affected in that particular syndrome or disease. Next up is von Willebrand disease. This is the absence or abnormal von Willebrand factor, or VWF. This causes impaired platelet adhesion. Some facts that you need to know about von Willebrand factor is it's produced by vascular endothelial cells and megakaryocytes, and it's stored in the platelet's alpha granules. So the alpha granules function in inflammation. They can help facilitate adhesion of platelets to other cells, and they also release a range of chemokines. And circulating von Willebrand factor forms a complex with factor 8. And factor 8 is important with helping your blood to clot. So if you look down here at this image, in normal hemostasis, bleeding is stopped because platelets stick together and a clot is formed. Okay, you see all the little blue dots is representing our platelets. They help a clot to form and bleeding is stopped. But over in von Willebrand disease, platelets do not stick together as they should, so bleeding is allowed to continue. Remember, we refer to the von Willebrand factor as kind of like the glue. The next disorder is Gleassman's thromboblasphemia. This is a rare autosomal recessive disorder. It's caused by the absence or deficiency of the platelet membrane GP2B-A2. And if you look over here on our receptors image, it's this one right here. It's this one right here that is affected. So this is a platelet membrane defect. It interferes with platelet aggregation and clot retraction. So again, platelets cannot carry out their proper function to help stop bleeding. Now we're going to talk about platelet secretion defects. These are disorders of platelets that release from granules through the open canicular system of the OPS. They usually involve the absence of platelet granules or enzyme pathways. So the OPS or canicular system is basically just a network of channels that are throughout the platelet. If you'll go back earlier on in the lecture to that image of all the different structures that you can have within the platelet, you can see examples of what the canicular system or the OPS system looks like. There's two storage pool deficiency or granular defects that we need to talk about. There's the gray platelet syndrome, which is a deficiency of the alpha granules that leads to an agranular appearance, and it'll show up on the right stain. And then there's the Westcott-Aldrich syndrome, which is an X-linked recessive syndrome, which is the hallmark finding is very small platelets. Patients also have thrombocytopenia and eczema with this syndrome. So this is just a cartoon to try to show and explain some of the disorders that we've talked about in this lecture. So this is the injured blood vessel wall. See, the hole here represents the injury. So the von Willebrand factor is represented by this hand and the finger trying to plug the hole. Remember, von Willebrand factor is the glue. Here's the platelet, and it's asking for help from the other platelets. And so platelets adhere to the vessel wall. So you need your von Willebrand factor and also your surface receptors for all these things to work. If your von Willebrand factor is not working or is abnormal, you may have von Willebrand disease. So decreased von Willebrand factor. If you have a defect in your surface receptor on your platelet, the GP1B9, you may have the Bernard-Soulier syndrome. Okay. If you the platelet calls for more platelets, you may have a storage pool disease or thrombocytopenia. Okay. If the platelets have a problem sticking together, okay, remember if they're called but then they don't stick together, then it may be a different defect from the receptor on the membrane of the platelet, and you may have Glasman's thromboblastemia. So this is just a cartoon to help illustrate some of the different disorders we've talked about that can affect platelets. The last thing that we need to talk about in this lecture is the effect of aspirin on platelets. Aspirin can be used as an antiplatelet drug. When aspirin is given to a patient, there's irreversible effects on platelet function because it inhibits the formation of thromboxane A2. The effect of the aspirin on the platelet begins 1 hour after ingestion, and it lasts the lifetime of the platelet. Remember, the lifetime or the lifespan of the platelet is about 9 to 12 days. This concludes our lecture on platelets. If you have any questions or need any further explanation on anything, please don't hesitate to reach out during lab or email or during my office hours.